So I have a very special guest today that I met at the World Conference, and she was giving a wonderful talk on hormone replacement. So I thought it would be really of value to have her share this with all of my followers who asked me lots of questions. And here's going to be the true voice of the expert. So I'm going to let Dr. Adriana introduce herself.
Thank you so much for the invitation. It's a pleasure to be with you and all the people that hear your channel. It's very important, your work, to let the women know what are their options for hormone replacement therapy. I am Adriana Orcesi Pedro. I'm a medical doctor, a gynecology for more than 35 years now. And I'm also associate professor of the University of Campinas in the postgraduate course, and also a current advisory member of the International Osteoporosis Foundation.
Wow, wonderful. So as I mentioned earlier, you gave this wonderful talk about hormones, and I know we're not going to go into such the depth that we did, but first of all, so much more interest in HRT. And a lot of women hear HRT, but could you actually explain what HRT stands for and what it means for women's health?
Oh, perfect. Well, when I say hormone therapy, or correctly, menopausal hormone therapy, we are saying about a variety of options of types, doses, delivery routes, and regimen of administration. And each kind has potential beneficial and some side effects. So it's very important when we say hormone therapy, we individualize what we're talking and what the proposal of this kind of treatment.
Great. When it comes to hormone replacement therapy, it's used interchangeably. Hormone therapy, hormone replacement therapy, right?
Yes,
okay.
Yes.
And so what are the 2 or 3 most important hormones for women as they consider hormone replacement?
Great question. It's important because the ovary that produces estradiol, progestogen, and also androgen, when women goes to menopause and stops the ovulation, she loses her estradiol and progestogen. The androgen will keep being produced for another gland, adrenal gland. But the estradiol and the progestogen, it's very low. And then when we think to replace, we are going to replace exact these 2 hormones. But each one has its function. So if a woman doesn't have uterus, we just need estradiol and not progestogen together. Each one has its objective when we prescribe.
When should a woman consider hormone replacement therapy if she has is concerned about menopausal bone loss? And oftentimes they don't know, but they see their mother and they don't want to age like their mother. They see, the effects of osteoporosis. So when should they start considering hormones?
Well, they consider hormones in all situations that these hormones decreases. That's very important, Margaret, because sometimes she'll be young. For example, women who has some gynecological or endocrinological problems or disease, maybe they are going to need hormones in a younger age. But usually we think about hormone replacement therapy when a woman goes to menopausal transition, not exactly after she's postmenopausal. She doesn't need to wait for 1 year without any period, any menstrual cycle to start hormone therapy. As soon as she gets all the fluctuations and symptoms associated to this period of life, she may have the prescription of hormone therapy. Depends on what she feels and depends on the worry that we have about their bone loss. And genetics, as you said, is her mom, her grandmother, his sisters. Genetics accounts for 60% of the risk for bone loss.
Way more than I anticipated.
Yes.
And since you are suggesting that they start even at the first signs of menopause. Is there a benefit to that? Like, does it hold off or stave off the loss of bones? Because everybody understands how estrogen, impacts the loss of bones. So do they start losing bone right away?
Yes. As soon as she has the decrease of her estradiol, the estrogen level, she may have the bone loss starting. And that's important because what we lose, we don't recover it. So the best way is not start losing, or if she lose, start right away. Don't wait so much, because sometimes when we are going to screen, her bone mineral density, it's already very low because she waits a lot. So it is important as soon as she gets like the menstrual irregularity, to look for their doctor and say about their risk factors, the clinical risk factor, there are many, for they to screen it and to see if she goes to a tool that is just a questionnaire about FRAX, that is a tool that we see her risk to developing osteoporosis, and then to see if she could go or she has indication to go to a bone densitometry.
Such a very important message, because so many women wait till they're 60, 65, and the government, now offers free screening. And by then it's so late.
Extremely late. And as I said, what you lose, you are not going to recover.
So many women will hear about HRT, unfortunately, well into menopause. And these women wonder, is it too late to start hormone replacement? So can you speak to that?
Yes. Well, all the latest studies, like 20 years ago or more, have shown that the best time for her to start, to have all the long-term benefits, it's in the window of opportunity. What we call window of opportunity. If she's younger than 60 years of age, it's not exclusive. It's better, but you cannot exclude if she's older. But the best is if she's younger than 60 years of age and until 10 years of postmenopausal, because she didn't start all the harm effects of the low level of estradiol. So we are going just to keep her as she was her life. Do you understand? Not to have coronary heart disease or cardiovascular diseases, or maybe another risk factor for metabolic disease. So it's better for you to keep as you were until the age of the menopause, and not to wait too much to start at 60. If a woman has more than 60 years of age and she's completely healthy, maybe we could assign her cardiovascular risk and to point for them the risk and benefits to take hormones in this age, and for she to take the decision.
And that's a really good point, because I hear about so many women trying to find physicians that when they want to take hormone replacement later in life, it's so very difficult for them to find the right type of physician. Mm-hmm. And sadly, so many of the North American physicians grew up with the Women's Health Initiative, and so they know very little about hormones. Do you have any advice to help women find and what kind of physician they should be looking for?
Yes, that's very important. Usually, we advise her to look for her gynecologist, because before we start hormone therapy, we have to check on her breast, to see the mammogram, to see her pap smear, to see her endometrium, if she has a high risk for endometrial cancer. We have to check all of these things, and gynecologist is able to check all of these things. And also, we are use it for hormone prescription, because since she was young, for example, most of the contraception is based on hormones. So this is very comfort for us to know about all these drugs and to prescribe according their risk and benefits, always thinking about that. So look for a gynecologist. And the Menopause Society, that was the former named the North American Menopause Society, we have a certification on menopause practitioner. I have this certificate. We do like a test, an intense test, to see if you are capacity to prescribe and to be able to see these women. So if she goes to the website, she can find, according to her zip area, which are the professionals that has this certification of the Menopause Society.
And these practitioners are worldwide?
Yes, they are worldwide. For example, in Brazil, I was the first one. But now I think that I already have 5 or 6. But for example, in the United States, there's lots of them. And to see what Menopause Society in America goes to their guidelines. And their guidelines are very aligned with the International Menopause Society. And all these guidelines says exactly what I'm saying.
That's excellent information, and very, very helpful. And we'll have a link to the Menopause Society at the end of this video. One big question that I get is, if I start hormone replacement, can I slow down or improve my bone status? Like slow down the bone loss or improve the health of my bone?
That's a very important question. That's, we always say, start early, not late. Because when you start hormone therapy, the estradiol, it uncouple the formation with the reabsorption. So it's a net gain and decrease the reabsorption. So she will stop to lose bones as they are. To gain, she won't gain. But one thing that is most important, it really prevents fracture. I do an analogy. For example, if you have high blood pressure, it's like asymptomatic. But if you treat high blood pressure, you won't have a heart attack. It's the same thing as osteoporosis. A woman can live with osteoporosis, but we don't want her to have the fracture. The fragile fracture, she will lose their mobility. 20% will die in the first year after a hip fracture, and they are going to lose their ability and mobility for routine life. Do you understand?
The day-to-day activity.
Yes, the day-to-day activity. So that's so important to start soon. And even the woman that's not start so soon, she's going to have osteoporosis, but she will prevent the final event, the frightening event, the fracture.
Okay, so at any point at which she starts the hormone replacement, she will cause the increased loss of bone that otherwise would happen, unless she took some other pharmaceutical drug. So at the World Conference, we had discussions about not just treating osteoporosis in its early stages, but looking at osteoporosis over the lifespan. And so I would really like Dr. Adriana to address this on how the use of hormones can be integrated into the lifetime of a woman's bone health.
If a woman is young, if a woman is in the postmenopausal year, under 60, less than 10 years of menopause, it has no contraindication, for sure, Margaret. Hormone therapy is the first option. These we have to keep in mind, because you see all other pharmacological drugs, they are excellent. They increasing. Some of them are osteometabolic, anabolic. That means she's going to gain bones. But you know, there are drugs that you can use for 1 year, at most 2 years, 5 years. If a woman has 50 years of age, she's going to use until she's 55. And what we can do for her until she got 85 years of age. That's why hormones, there's not like a limited time for you use. So you can take hormones until you're 60, 65 or more. And when she gets older, then you can use the other medications, but not so young. Unless she has fracture or high risk of fracture, we can associate hormone therapy and also another drug. Do you understand?
Yes.
But don't use a very potent osteoporosis drug in a younger age. For sure, if she doesn't have any contraindication, hormone will be always the first option.
So if you are a parent or a grandparent, one of the best gifts you can give to your child or your grandchild is the health of their bones. And so I'll let Dr. Adriana talk a little bit more about that.
Excellent. Do you know, Margaret, people only think about osteoporosis in older age or if she has a fracture or when she goes to menopause. No, it's not our idea. We have to care for bones all their life. Do you understand? It's a lifelong bone care. So, for example, in a child, to have a very good nutrition with calcium and vitamins, and when she goes to the adolescent or the teenager, for you to have an idea, the peak of bone mass, it's until 18 years of age, very young. And when the girl has their breast development around 10, 12, 13 years of age at puberty, she's going to gain 80 to 90% of total bone mass. She's going to take this for her life. If she has a very good bone peak at the puberty, it's one of the major protection against fracture. So the teenagers usually doesn't like milk, doesn't like dairy products. They are just on the cell phone. They don't do more exercise. They don't get like sun exposure. So this is important for the teenager. For you to have an idea, a teenager needs 30% more calcium than a woman in adult age, more than a woman at menopause, for you to have an idea. Another thing that is important, how to choose your contraception. There are some contraceptions that will help her bone mass. And also during pregnancy, a woman needs calcium intake. She needs vitamin D. The last guidelines of vitamin D, it's empiric supplementation during pregnancy. She needs in the lactation period almost 50% more of these nutrients. And after, in the menopause and senility. So we have to think all her life, not only when she gets at menopause.
Excellent. That's so very important. Thanks for that message. So protecting our bones from a young age is so very important, but sadly, most people find out about their bones after they've had a DEXA and they're told, oh, I need you to start a strong pharmaceutical drug or a bisphosphonate in order to protect you from either a future fracture or potential fracture. And so, what is the role of estrogen in that? And can it be paired with a pharmaceutical? Dr. Adriana?
Yes, that's what we're doing this conference. Do you know how many things you could see as news? For example, for a woman, if she has a high risk, is young, probably you can start and you will start hormone therapy, but she will benefit like for a short period of osteoanabolic drugs or for a short period to her keep up with her bone and increase it and then maintain her with hormone therapy for a long time. This is something that is changing. And even if she's taking hormones and in a certain moment she loses more bone because she has a disease or she's going to treat a cancer or anything, and she's going to lose accelerated her bone loss, you can introduce a drug, a pharmacological drug, to treat their accelerated bone loss for a period and then keep with her hormones.
And that follows through the concept that if you start hormone replacement, that is something that you could use for a lifetime. Am I correct?
Yes, for a lifetime until you see when you have the balance of your benefits and your potential risk or potential side effects. So you can use for a long time. About 1 year and 6 months ago, at the Menopause Journal, there's an important publication about a study that for more than 10 million women follow up for 14 years after 65 years of age. And what they compare, women who took hormones in the window of opportunity and keep taking after 65 years compared to one that never took or the ones that took hormones and stopped it at 65. The women who kept using have longer life, less lung cancer, less colorectal cancer, and better results in cardiovascular disease. And so she was better than women who stopped it. But everything has to be individualized. You have to keep your prescription or not depending on your follow-up consults or to see your doctor and to see how is your health at that moment and what is the better option for you to keep taking or to decrease the dose or to change for another one. So we have so many options available and everything has to be according to your benefits at the moment.
That's a great way to say that having a good relationship with your physician who is prescribing the hormones is so critical, and that individual is well trained and versed in all of the potential different hormone possibilities and availabilities. A couple of years ago, when I was seeing a gynecologist in Canada, there was a new medical graduate in gynecology, and I asked her specifically, so what did you learn in regards to hormone replacement? And she said, absolutely nothing. And this was, I'm talking 3 years ago in Canada. And so as women and as the fathers and spouses of all the women that you love, it is so very important that we raise our voices. And there was an example of a movement that I'm going to let Dr. Adriana speak about. And this was the UK Warriors. Am I correct?
Yes.
So go ahead.
Yes, it's the Menopause UK Warriors. That was so important. And do you know the British Menopause Society, the slogan is start conversation. And do you know the women has to be empowered and very active. If she requires there will be going to change many things. You know, it's not only the medical school, and this is worldwide. Even the doctor that goes to a resident program on gynecology and obstetrics, what they learn about menopause and hormone therapy, it's very short time. And this is lacking because the women now has more knowledge and they require of their physicians. So the woman has to be active and ask their doctors for they to get informed. And also in UK, they make like a requirement to change the medical school curriculum to put like a course, a whole course during the medical school about menopause. Do you understand?
Yeah.
For the general practitioner, the clinicians, the gynecology and obstetrics, the geriatrics, the endocrinological, or the cardiovascular, all the specialty must know about menopause and their consequence. Because nowadays, in the world, we have 1,200,000,000 women after menopause. Annually, 47,000 women go to menopause. And do you know, in my country, and I think that all countries, 60 to 90% will have other some symptoms. And from these, 60 to 92% will search for medical advice. And can you believe you go to a doctor and the doctor doesn't know what to do? That's very sad. Or have, worse yet, that all the concepts of the WHI. That's worse. because they are linked to the older thoughts and the older, what science said 26 years ago. The doctor has to be updated. The FDA did a very good issue about this. The FDA goes to public and said what is about hormone therapy, the prescription. They took it off the black sign, yes, the black
box warning.
Yes, and this has to go to the public. That's why your work with your followers are so important.
So we need to raise our voices because we need to help our girls, then the generation behind us, those of us who might be frustrated and going, wow, I missed my window, but we don't want the next generation to miss their window. Dr. Adriana, a lot of women will shy away from hormones thinking that it's going to make them gain weight or build big muscles, and they're a bit nervous about that. So do you mind speaking about that?
Oh, that's excellent. Okay. The hormone therapy, once they gain weight, the age and the menopause, yes. Usually with menopause, without the protection of estrogen, women will gain fat in their abdomen, and the worst fat for cardiovascular risk. So if she's not active and she keep eating what she ate all her life, and if she doesn't worry about this, she's going to gain weight. It's not the hormone that is going to make her gain weight. And there's something that is very interesting. The metabolics, and also all the energy and everything that hormones brings will make her, if she kept on exercise and diet, to have, it will be a little bit easier for her to lose weight. And the fat distribution will be the gynecological distribution, not in the abdomen. So hormone, in this case, will only help.
Excellent. Thank you. That's very good information and news for a lot of women. Could you say a few words about hormone replacement and muscle function? Does it alter women's strength, either good or bad?
Okay, the strength, they are just going to maintain, not gain. To gain, you really need to exercise. And one thing that is very important, the sarcopenia. Sarcopenia, with age, you are going to lose your muscles. So if the woman is not active, like varying weight or the flexibility and everything that she can have, this will be all the difference for her to have a healthier, older age.
Very good. Thank you. Would you mind saying a few words about the effect of hormone replacement and bone structure? Because we know, a lot of women are very well educated on bone density, but also on bone quality. And so could you speak about that?
Yes, that's very important because it's not only the quantity, the microarchitecture of the bone, it's so important as the quantity of bones. And hormone therapy will keep a healthy structure as it was all her life. So it will be bone quality.
So the quality of the bone is
Yes,
maintained.
it's not the maintenance of the quantity. The quality will maintain also.
And that's so very critical because so many women will have scores in the osteopenic range, but they still fracture, sometimes more so because of the poor quality of their bones. Whereas some women will have very poor scores and be in the osteoporotic range, but the quality of the bones are good and they're not fracturing. So the importance of hormones on maintaining bone quality is a really good positive impact for bringing in or maintaining hormones through our lifetime.
For sure. And quality is something very difficult for us to measure.
Yeah.
That's why it's so important to all the drugs that exist to treat osteoporosis to see the quality too, not only the quantity. And this we explain for patients all the time because usually when she goes to therapy, she wants to see her bone densitometry to increase. This is not the target of the treatment. the treatment is to maintain your bone and avoid you to have the fragile fracture.
So a lot of individuals who are starting hormone replacement might be talking to peers that are younger, and all of a sudden they get a dosage that's different than what their younger friends have. And so could you speak a bit about dosage of
Types.
and types of estrogen as well as progesterone? But let's start with the estrogen.
Okay. The estrogen is the major principle of hormone therapy because it's the estrogen that will keep her from not having the symptoms, vasomotor symptoms, emotional symptoms, mood change, to keep your genital, yes, the hot flashes, night sweats, and everything like that. And also to keep their genital urinary health. That is so important to avoid urge incontinence, urinary incontinence, that is terrible. And also to keep her vagina moisture, not have vaginal dry, painful intercourse, that really skip apart the couple. It starts in the sex life and then with their lives. So it's important, and also to prevent bone loss and osteoporosis. So estradiol will do all these good things and more things to keep your collagen in your skin, to keep you to postpone your osteoarthritis, yes, and everything. So estradiol does everything.
So could we now speak a little bit about the delivery of progesterone? Because we know that for women with uteruses, that if they're going to take estrogen, they also end up taking a progesterone.
Yes.
So a few words on that.
Okay, that's very important. It's I want to make clear that when you take orally progesterone, there is no liver test, so it's safe to take. But you can also use natural progesterone in the delivery in vaginal route. Usually women doesn't like so much to keep insert pill inside the vagina. So usually we use it orally. Another options of progesterone to protect the uterus. In the patch, it's combined with estradiol and noritestosterone acetate. This is a synthetic progesterone, but it's a very good progesterone because it's also acts in estrogen receptor. What does it mean? It has synergic actions to relieve symptoms. And what is the final result of that? Even if you use the lowest dose of estrogen with noritestosterone, the symptoms and the bone outcomes, it's better than to use the natural progesterone. And we don't have natural progesterone to use the transdermal, just the noritestosterone.
Okay, so this was a lot for people to absorb, but really in listening to Dr. Adriana, I went, wow, this is the reason you want to see a gynecologist and make sure that the prescription that you get is really looking at your health history and taking that into consideration. Would you mind speaking more specifically now about the dosage? If somebody's just entering menopause and they came to see you and otherwise healthy, what would be their dosage versus a 60-year-old who's 10 years postmenopausal?
Okay. About the dose, it's very important. If your woman is very young, like less than 45 years of age, and she goes to menopause, we have to give a high dose to keep her estrogen level similar to their age. But if a woman is in the postmenopause, we usually go to lowest effective dose. That will be the low dose or the standard dose. That is important. But if a woman is older, usually we choose the lowest dose. It's important to say that for symptoms, the standard or the low dose, it's enough. For example, if you keep your estrogen level around 30 to 60, you won't have like vasomotor symptoms, the night sweats, the hot flashes and everything, and a very good health, genital health. But if we think only about bones, even the lowest dose is still very good for bones. But the bones has a dose response. So the higher dose, the better protection. The lower dose is still you have the protection, but you'll be less than standard or the low dose.
Now, when you mentioned the level, the 40 to 60, is that a blood test level or that's the level that's given, in the medication?
No, the blood level. We don't need to check your blood. Okay. We just check if you are good in your symptoms. The clinical. If you don't have more vasomotor symptoms, night sweats, sure you're going to have this level. And also, Margaret, all the available estrogen for prescription that has all the authorization like the FDA, the EMEA, in Brazil, the Anvisa, we have all the pharmacology of this drug. We know exactly when I'm giving this dose, what level you are going to have. This is not something that you produce in a pharmacy. It's all the pharmaceuticals that is allowed to produce. We have exactly the blood level. We don't need to check.
Excellent. Thank you. Would you mind, something we didn't speak about is just the delivery route. Is it taken orally, which, with the Women's Health Initiative once was a lot of oral estrogen. I use patches only because I don't like putting cream on my arms because I get cold in the morning. Mm-hmm. But what are the different delivery routes and the benefits of different ones?
Excellent question. Okay. Just for you to have an idea in your followers, the most used hormone therapy is oral all over the world. Is oral.
Really?
Yes, is oral use. Because, yes, most of the women, because it's easier, it's cheaper also. This is the most used. But what are the recommendations, the medical recommendations? The transdermal is more likely the biological hormones because it doesn't have the first liver path. For example, when you take it orally, it goes to the intestine and then goes directly to the liver. In the liver, we will increase some factors that's not so good for the health. For example, we will increase some factors that has a more thrombotic profile, or even for a woman who has high blood pressure, it produces some protein that will unbalance your blood pressure for a woman who has the disease, not for the normal woman. And also, it will increase a protein that's called sex hormone binding protein or globulin. And this will attach to the testosterone and decrease the free testosterone that it has the bioavailable testosterone that is good for sexuality. So the oral routes has this disadvantage. That's why usually nowadays the recommendation is the transdermal route. And we have in gel, in patch, and also in a spray. And they have a very good level of estrogen that keeps her with all the benefits of the orally used.
Now, my understanding, and so you can clarify this, is women who are starting later, if they are given one version versus another, that they might have a risk for blood clotting.
Yes.
And so you were saying that the oral is the most popular, but is that not the one that will put you at risk for blood clotting?
Yes.
Okay.
That's why nowadays all the medical recommendations for transdermal, mainly for women who is obese, that have more risk for thromboembolism, you are not going to give it orally. For a woman who has very complaints about sexuality, it's not the very good way or delivery route. For a woman who has high blood pressure, also for a woman who has high triglycerides, because it will increase the triglycerides. Wow. So for all these kind of women, for sure, orally is not a good delivery route. And also for older age, because older age you have more cardiovascular risks associated. That's why also the transdermal route will be fine. And Margaret, we have a new estrogen that's called estetrol. It's available in Canada and United States as a contraceptive. But soon, probably, you are going to have all over the world for menopause. And the great thing about this estrogen that's called estetrol, it's because it doesn't have these kind of problems in the liver, and you can take it orally. So soon we have a news or an innovation in the orally route.
Excellent. Thank you. That's good news for a lot of people because I think it's probably going to be easier to take.
Yes.
I mean, it's oral, but also hopefully less expensive.
Yes, I don't know this part because it's a new drug, and then they usually, when it's an innovation, they have high costs.
In thinking about, the different options that we have in regards to obtaining hormones, we were chatting a little bit, and Dr. Adriana came up with something that she, remembered that I only knew as a contraceptive device, but I guess is now used also to help women in menopause. So,
yes, that's a very good option. It's the IUD called Mirena all over the world. It's the same name. And this is very interesting for women perimenopausal when it starts that abnormal uterine bleeding.
Oh, in the perimenopausal
Yes, the
period?
perimenopause, for example. She inserted the Mirena for contraception or for abnormal uterine bleeding. And she goes through menopause. That's very important because the protection of the endometrium will keep. And then you just give estrogen. Do you understand? And then for menopause replacement therapy to protect the endometrium, it will last 5 years with safety. After 5 years, you have to change. So for the human who has a lot of side effects with the progestogen, some women who takes progestogen systemic, maybe they have depressive mood or water retention, or looks like she's having like a premenstrual syndrome with progestogen if she had before. And then a very good option is the Mirena, because Mirena, the mainly action, it's inside the uterus to protect endometrium and not systemic. So it's a very good option for women with postmenopausal years.
Wow. So I was actually thinking as you were speaking that for so many women who are having a hard time in their perimenopausal period, they're still worried about getting pregnant.
Yes.
That they could approach their physician to get Mirena, and they'll get the hormone protection as well. And hopefully within 5 years, if they change from Mirena and they want to do hormone replacement, that the world will have advanced a little bit more and doctors will be more familiar with the use of hormone replacement. So this would be a really nice surrogate at this time.
Perfect, because it protects her with all that menopausal transition that is very bad when it starts the bleeding. And she has symptoms. And then you have to give estradiol and you make it worse, the bleeding. You understand? So Mirena will protect from everything, and you just give the estradiol at this phase. The adaptation, clinical adaptation for the woman, it's excellent.
Great. I think this is a really good time to wrap up. I just want to thank you so much. I wish I lived closer, but maybe I'll visit you in Brazil one day.
It will be a pleasure. Or one day, or we keep sharing, or a video, or anything.
Excellent.
Because it will be very good. And I think that your role to take the right message for your followers and to empower women to require more things from the physician. And it's very important, the knowledge. Knowledge is power. Power for you to decide what you want to do, what you are going to require, what you say for your doctor. If you don't have this knowledge that Margaret so kindly passing or talking to your women, it's difficult for them to have a dialogue. And I think that conversation is the way. But a conversation with knowledge and to see what all the sciences, the important medical societies tell us. It's so important for you to be here in this conference, for you here, what the leader of opinion, medical and science opinion has to say about all the science that is just published.
So thank you so much for sharing your vast knowledge on this topic, and we really appreciate your time.
I appreciate. Thank you for the invitation. It was a great pleasure for me.